My name is Tracey Li. I'm presenting submission DAP 2023-0157, which is called Operationalizing Health Data Governance for AI Innovation in Low-Resource Government Health Systems, a Practical Implementation Perspective from Zanzibar. I'll begin by talking about the background and context to our work. Our starting premise is that the benefits of health AI should be equitably distributed. In order to achieve this, governance of AI and data are necessary to ensure that AI is reliable, safe, trustworthy, fair and equitable, as well as being accurate and efficient. And those governance frameworks need to be operationalized, not just created and defined on paper, in order for real-world changes such as increased equity to materialize. Whilst there are many initiatives focused on creating governance frameworks, we focus on operationalization or implementation. And implementation can look very different in different contexts. Our paper is based on real-life implementation conducted within the Zanzibar public health system since 2022, and we believe that many of the findings described in our paper are generalizable to government health systems in other low and middle income countries, abbreviated to LMICs, and which I also refer to as low-resource health systems. The paper was a collaboration between three partners. The first is D-Tree, who I work for, and also my co-author, Mr. Abbas Wandella, works for D-Tree. We are a non-governmental organisation providing technical support to the Zanzibar Ministry of Health. Then we worked with the Zanzibar Ministry of Health, where my co-author, Mr. Mohamed, Al-Mafazy, is from, and that's a government body responsible for the health system in Zanzibar. And our third collaborator was Dr. Richard Gomer from the University of Southampton. That's an academic institution with researchers such as Dr. Gomer who study data governance mechanisms. Why do we focus so much on operationalization? Well, the goal of data governance isn't to create regulation and policies. The goal is, or should be, to maximize the benefits of data use, such as maximizing good health, whilst minimizing the risks to individuals and communities. To achieve this goal, regulation and policies need to be translated into real-world actions which need to be practiced. And although there's plenty of evidence that the operationalization of data governance frameworks, such as the GDPR, is difficult, the topic isn't widely addressed, and we'd like to bring more attention to this subject. As to why we focus on the LMIC context, this is because health data governance is needed everywhere, so there needs to be attention focused on low and middle income countries as well as high income countries. Digitization is facilitating increased data collection in LMIC health systems, but without robust data governance, that data is not being used effectively, safely, and equitably. And we should remember that, as in all countries, the health data collected in LMICs is very sensitive, and also many health programs in LMICs are targeted specifically at vulnerable groups, such as young children, pregnant women, and people living with HIV. Also, we'll note that the environment in LMICs is different from that of developed Western contexts where most discussion about data governance is focused. And there are many differences which affect the operationalization of data governance frameworks, such as the level of infrastructure, especially electricity and internet. The level of education and digital literacy can affect how you communicate with people about data, the availability of resources to operationalize governance frameworks, and also cultural values, which can affect how certain decisions are made. The photos on this slide are just showing at the top a government health clinic in Kenya, and the one at the bottom is a setting in Europe. And this just shows that although there's the same basic equipment, such as computers in both of these settings, the age and reliability of that equipment, and also things you can't see, such as the infrastructure, electricity, internet, and so on, are very different in these two settings. In our paper, we discuss three aspects of health data governance. So we have not tried to comprehensively cover all of health data governance. We focus only on the following three topics. They are, firstly, obtaining informed consent to reuse health data for research and AI innovation. Secondly, implementing data access management and data security policies within a health system. And thirdly, a discussion about data quality and the limitations posed by a low-resource health system. I'll talk now about the first part of our paper, which is about obtaining informed consent to reuse health data. Informed consent is a core principle of many data governance frameworks, and what informed consent should do is empower people to make meaningful, informed decisions about how their data is used and reused. However, in reality, informed consent is often reduced to a superficial box-ticking exercise that doesn't provide people with meaningful understanding or control over their data. That's partly because there are many challenges to obtaining meaningful informed consent in LMICs, although there are many challenges in high-income settings too. For example, a lot of terminology about data use was developed in English, and not all of it is easily translated into other languages. Secondly, low levels of data literacy in some low-income countries mean that people may not be familiar with concepts and terms related to data that are otherwise widely understood in developed contexts. Also, consent cannot always be obtained and documented in writing due to limited literacy, and the individual consent model used in Western contexts isn't appropriate in all cultures. In Zanzibar, we actually wanted to find out how well informed people are currently about how their data is used and reused. And so we conducted a survey of 97 people who are enrolled in Zanzibar's community health program to ascertain their level of awareness about how their data is being used. Here's a brief summary of some key findings. We found that 44% of respondents were not aware of who could access their data, and 32% didn't know why their data is collected. We didn't verify whether the respondents who said they did know why their data is collected and were aware of who could access their data, whether they actually had an accurate understanding, and therefore we note that both of these percentages that I've written here might actually be higher. We found also that 1% of respondents had concerns about their data being shared with health program staff, health facility staff, or government staff, whereas 4% had concerns about how their de-identified data was being shared with researchers within the country, and 5% had concerns with their data being shared with researchers in other countries. The concerns that were expressed were related to confidentiality, embarrassment about health conditions that were going to be shared, about data going far away, which indicates a lack of understanding about how the physical or virtual aspects of data management, and also not understanding how they would benefit from their data being used in this way. And what we were trying to get to was to find out, do we think that we could better inform people about how their data is being used? We found that over 95% of respondents were receptive to receiving more information about how their data is being used by various stakeholders, and that a large proportion of respondents lack understanding about who can access their data and why those people have access, but they are generally comfortable for their data to be shared with at least in-country stakeholders. So after that, we believe that we can improve communication within this context of Zanzibar's community health program in order to increase understanding and enable more meaningful consent for data use and data reuse, but without causing undue fears amongst people. I'll move on to the second part of our work now, which is about implementing data access management and data security policies within a health system. So as I said earlier, many policies are created, but they're not implemented, and there's an increasing amount of digitization of LMIC health systems, which is enabling more health data to be collected. There is investment in technology in order to facilitate this data collection, but not much investment in providing tools and training to enable governments or other local partners to manage that data effectively and securely. When there is support, it's generally limited to defining principles for regulation at a national level or at an organizational level. Support is there to create policies, but doesn't extend to the implementation of those policies. And so the problem here is that the language in policy documents is dense, complex, and deliberately non-specific because policies have to cover a broad range of scenarios. So that makes it difficult for most people to understand how policies apply to their work. Policies need to be translated into guidelines, standards, and procedures that staff at all levels can follow, and it's essential to note that different staff require different guidance according to their specific role. This diagram here is just showing the main stakeholders in Zanzibar's government health system, and it's the frontline health workers working in health facilities who are the ones that collect data from patients, and so they need to know what is good practice for collecting data directly from patients. Those facilities and frontline health workers are managed by council, district or regional health management teams who oversee the management of those hospitals, but also then the data collected within those hospitals and facilities. And then staff at the National Ministry of Health level are responsible for overseeing the whole health system and also overseeing the overall management of data collected within the health system. Those stakeholders have very different roles and responsibilities with regards to the management and use of data, and therefore guidance needs to be tailored to each of them accordingly. I'll talk now about the actual implementation that we've been conducting in Zanzibar. And the start of this is that in 2022, a data protection policy had been created for the Zanzibar Ministry of Health, but without any planned follow-on actions. To facilitate then the operationalization of that policy, we at D3, together with the Ministry of Health, did the following. Firstly, we had to build consensus amongst Ministry of Health leadership for the initiative so they understood why this policy needed to be operationalized and so that everyone agreed to work together on this. That process took approximately 6 months. We then formed a committee of key technical stakeholders and provided them with some basic training and awareness to make them understand the content of the policy and what we would be doing for the implementation. That took about 3 months. With that committee, we then co-created an operationalization plan, including prioritization to identify the highest priority areas. And it was important to ensure that that plan was officially authorized, signed off by senior officials. That was about 3 months in total. And then at that stage, we had to go and secure funding and also make sure we obtained buy-in from all necessary stakeholders. That was another 3 months. From then, we were able to proceed with the actual implementation of the highest priority topics, which the Ministry of Health Committee informed us were data access management and data security. So what we did there was we co-created guidelines and standards with a diverse range of stakeholders, primarily from the Ministry of Health, but also from other government bodies and other implementing partners. That took about 6 months. We had to ensure the official adoption of those guidelines and standards, which basically means getting sign-off and formal approval from the highest levels at the Ministry of Health. That was 3 months. We then translated into Swahili, which is the language of Zanzibar, and printed and disseminated those guidelines and standards. That was 3 months, and these are just pictures of the guideline documents that we created. And then currently we are training staff to ensure that they're able to follow those guidelines and standards. So altogether, it's been about 2.5 years so far, and that training, as I said, is still underway. So will be several more months still before we get to the end of that process. Key takeaways from this implementation process are the following. Governments have limited technical capacity and resources, and therefore a lot of external support in terms of funding, technical input and facilitation is required. There is limited funding available for developing the human capacity and processes needed to implement data governance policies. Most attention is focused on policy creation or technological solutions, but not so much on developing human capacity and processes. It's necessary to respect hierarchies and bureaucracy within governments. This means engaging with several high-level stakeholders at the right times and doing that at multiple times throughout the process. And operationalization is a long and slow process. As I said, it's been about 2.5 years for us so far, and we're still very much in progress. Therefore, this means that we require long-term commitment and long-term focus from all stakeholders. Moving on to the third part of our work now, this is about data quality and the limitations posed by a low-resource health system to data quality. Many health data governance frameworks promote the reuse of health system data for AI innovation, but don't address the quality of that data. And it's important to highlight the differences between data collected within within the health programs of a health system as a byproduct of health service delivery compared to research data. If we think about survey or research data, that data is collected by data specialists using a specially designed sampling frame. That is to ensure adequate representation and adequate data quality for a specific research study or innovation project. In contrast to that, the data collected within health programs within a health system is data from patients that's collected by healthcare workers and from whoever obtains health services. And the data is collected to facilitate service delivery, not to facilitate research and AI innovation. Given that, the quality of the data collected from health programs and health systems has several limitations, which are representation. So because data is only collected from people who seek and receive healthcare, that doesn't mean that all groups in your population are going to be represented in the data, because not all groups will be seeking or receiving healthcare. Level of detail in these data sets is often lacking because data collection is often minimized to reduce the burden on health workers for collecting that data. Remember, data is collected by health workers whose primary responsibility is to provide patients with healthcare, not collect data. Data collection is a secondary duty for them. Lack of standardization means that there's inconsistency between data sets, sometimes even between the data collected between two different health facilities from the same health program can be inconsistent. That makes it difficult to combine data sets from different locations. There's a certain level of inaccuracy which is due to lack of staff training, meaning that sometimes staff don't know how to, for example, correctly report or diagnose certain conditions, leading to misreporting, but also intentional misreporting occurs if there are fears about blame or penalties for negative health outcomes. And finally, there can be missing data, which is due to a lack of medical equipment that's needed to collect that data. For example, pretty basic medical equipment such as blood pressure monitors that are needed to collect blood pressure measurements aren't always available or functioning in all health facilities. Therefore, it's very important to produce comprehensive documentation to highlight these limitations if data is going to be reused for research or AI innovation. So, good data governance and technology can't, by themselves, elevate the quality of health system data to the quality required for AI innovation. Data governance and technology can improve the data quality, but not necessarily to the level required for AI innovation. For that, more staff, better training and support, functioning medical equipment, and sufficient medical supplies are all necessary if we want to make the quality of data be sufficiently high for research and AI innovation. And all of these things are anyway necessary for improving healthcare. And as a final note, staff, equipment and supplies are also necessary if we want to effectively use AI outputs, specifically diagnostic outputs. Because whilst AI can produce a diagnosis for a patient or can predict whether a patient will suffer from a particular condition in the future, in the end it's the staff, equipment and supplies that are needed to provide treatment to that patient to prevent a negative health outcome from occurring. So the AI by itself has no effect on a patient's health outcome. You still need the healthcare from staff, equipment and supplies. Summary of our work then is that informed consent is a common principle in health data governance frameworks, but there are many challenges to obtaining meaningful informed consent in low and middle income countries. Data governance policies have to be translated into actionable guidelines, procedures and standards that staff can follow in order for there to be any benefit from those policies. This requires a lot of time, resources and inclusive participation that are typically not considered or discussed. And finally, the reuse of health system data is promoted by many data governance frameworks without taking into account the quality of that data. The data quality in low and middle income country health systems is inhibited by shortages of staff, equipment and supplies, which can't be rectified by data governance mechanisms. Thank you.